I'm Christy Maxfield, nurse practitioner at the University of Colorado Hospital. I am in electrophysiology. I am primarily clinic-based. Um, I have a lot of slides. I don't know if I'm going to get through them, but if there's something that you want to hear more of or less of, just let me know. I have no disclosures. So I'm originally from West Michigan. I lived in Minneapolis for 20 years. That's the picture in the middle. That's the Minneapolis Sculpture Garden. And there's an iconic sculpture called the Cherry and the Spoon. And I moved to Colorado a little over 3 years ago. So happy to be here. So I'm going to go through a systematic approach to interpret EKGs. To be perfectly clear, I'm not sure where you all are starting from or what your background is. This is going to start very basic. Hopefully it's a review, but if it's new information, I hope it's helpful. So I want to get through an approach to rate, rhythm, intervals, and then we'll go through some arrhythmias, EKGs, and case studies. I'm assuming that many of you all will have a ECG monitor that gives the heart rate, but there is a way to calculate heart rate off of EKG or telemetry. There's a small box method and a big box method. But as you know, there are small boxes measuring 0.04 seconds or 40 milliseconds, and 5 of those make up one large box, which is 200 milliseconds. So when you're looking at the little boxes, there's 1,500 small boxes in 1 minute. And when you count the number of little boxes between the R to R interval, you divide that into 15, and that gives you the beats per minute. Large square method, I use this a lot, especially when I'm looking at device interrogations, because on those EGMs, you don't get an automatic heart rate reading. But there are 300 large boxes in 1 minute, and you divide the number of large boxes between the R to R interval into 300, and you get the heart rate. So 1 big box, if the R to R interval is 1 big box apart, it's 300 beats a minute. 2 is 150, 3 is 100, 4 is 75, and 5 is 60. After that, the formula becomes a little less reliable. As you probably know, the definitions for bradycardia, tachycardia. So systematically, we look at rate. We look to see if the R to R interval is regular or irregular, if the QRS morphology is narrow or wide, and if there are P waves, are they absent or present? And if they're present, is there a P wave for every QRS, and do they associate? So this is just a tracing of normal complexes. The P wave is a tracing of the electrical activity in the sinus node. The PR interval is the length of time that it takes the sinus beat to conduct down to the AV node. And then the QRS complex is the amount of time it takes that electrical impulse to spread across the lower chambers. And this is just a EKG of sinus rhythm. The rhythm strip is down here. The rate 300, 150, 175 beats a minute. It's regular. The QRS is narrow. For every P wave, there's a QRS. So sinus rhythm. Getting into the AV blocks, first degree, second degree, and third degree. First degree blocks are when that PR interval is greater than 200 milliseconds. Second degree type 1 is that winky block where the PR interval will get progressively longer until one beat is dropped. And the pattern recognition for that is there is often grouped beating. Second degree type 2 is the higher grade AV blocks, such as 2-to-1 or 3-to-1 AV block. And then third degree block is complete heart block. And you may see P waves and you're going to see QRS waves, but they don't associate. Here's an example of first degree AV block. For every P, there's one QRS. It's just that the PR interval is longer than 200 milliseconds, probably closer to 280, 300. But everything still gets to where it needs to go. It just takes a little longer. Second degree type 1 winky block. Again, there's a P wave for every QRS, but the PR interval becomes longer until there's a P wave without a QRS behind it. And then everything resets and you can see the P wave after the drop beat, that PR interval is back to normal and then everything starts to prolong again. I would say that generally people are asymptomatic and otherwise unaware of winky block. As first responders, it's very possible that you have seen or will see people with higher grade AV blocks. The PR interval does not lengthen. Then there can be dropped QRS without changes to the PR interval prior. So someone can be in a regular rhythm with normal intervals, have a P wave without conduction behind it, and then it picks up again. Again, this is different than winky block because these PR intervals do not change. It can be intermittent. You could have one drop beat, you could have multiple drop beats. It's highly variable. This is a 2-to-1 block. But again, there's still a decent ventricular escape rate, 300, 150, 175, 60, little less than 60 beats a minute. So that patient, I would hope, would still be perfusing. Third degree heart block is where there's going to be more P waves than QRSs. The P to P interval will be regular. That will march out. The R to R interval will march out, but there's going to be no association between the atrial activity and the ventricular activity. And the escape rate on this one is like probably 30 to 40 beats a minute. I think I'll briefly just go over sinus node dysfunction. Um, and then talk about causes and treatments for both AV block and sinus bradycardia. Um, so sinus node dysfunction is highly variable. Sometimes people can just have baseline sinus bradycardia that's likely asymptomatic, or it can go all the way to having the sinus node arrest completely. Sometimes that's accompanied by a junctional escape rhythm, sometimes not. Um, Tachybrady syndrome and chronotropic incompetence, I probably won't cover because I don't think that that is, especially the chronotropic incompetence, something that you're going to necessarily be seeing or need to treat as first responders. This is basically when patients can't augment their heart rate with activity, so they might have a normal resting heart rate, but when they're exerting themselves, they're going to have a blunted heart rate response. And generally, it's not an emergency or an urgent situation. But in any case, oh, this got a little out of place, but this is a patient who I've followed for several years. At baseline, you can see he's in sinus rhythm, but has a very long first degree. This has been asymptomatic. It has been somewhat progressive in that that PR interval is lengthened over the years. He has since been complaining of fatigue and falling asleep easily and sometimes feeling dizzy and lightheaded. I put a Zio monitor on him, and there are times where he is blocking down. And here the escape rate on average was 21 beats a minute. So we're going to put a pacemaker in him. This is just a ECG tracing of profound sinus bradycardia, but for every P wave, there's a QRS. So no AV block issues. This is a patient with profound sinus node dysfunction. You can see there's a P wave for every QRS. Heart rate's very slow, and then that sinus node just stops for a prolonged period of time and eventually picks up again. This, I'm going to skip this. Actually, I'll go over this one. This is another patient of mine. She's 51. She's otherwise healthy. She has this really interesting history of where she has just tons of SVT, but then she will also get, she'll convert out of the SVT and then have these conversion pauses. And initially, someone talked with her about needing a pacemaker, being 51 years old and needing a permanent device placement is not without its long-term perils. So what we ended up doing was ablating her SVT, and it actually reduced the number of sinus pauses that she was having. Hasn't gotten rid of them completely, but they're definitely better. And as you can see here, she had a significant pause. Sometimes when the sinus node doesn't work, the junction, the AV node takes over. So sinus rates are typically 60 to 100. The rates at the junction are going to be a little slower, probably somewhere 40 to 50 beats a minute. And as you can see, there's no P wave, regular narrow QRS. So this beat is being initiated from the AV node. Mm, I'm going to skip the tachybrady. True tachybrady is for someone who has atrial fibrillation, they pause and then they convert back to a normal rhythm. Um, Generally, not seen in emergent situations, but sometimes that pause can be long enough that they may have pre-syncope or syncope. Moving further on down the electrical cycle, looking at the QRS complexes and thinking about bundle branch blocks. So when we look at that QRS, eyeball, is it wide or is it narrow? Normal QRS duration technically is less than 110. If it's between 110 and 120, it's like an intraventricular conduction delay. 120 or higher, then likely some kind of bundle branch block. These can be associated with pathological conditions. However, I feel like the right bundle branch block, you see that more in just conduction disease, especially in our older patients. Um, I always tell patients that our heart's electrical system ages with us. And just like the electrical system in a house, the wires of the heart can become frayed. Um, let's see here. So intraventricular conduction delay is a somewhat wide QRS with a duration of greater or equal to 110 milliseconds, but it doesn't otherwise meet criteria for a bundle branch block. Generally, patients are asymptomatic with that. Right bundle branch block in V1 and V2, there's upward deflection initially, and it can look like an M. In V5 and V6, there's a broad and deep S wave. Left bundle branch block in V1, V2, there's a deep S wave. V5 and V6, it's very, the QRS is very broad and it can be notched. A couple of different ways to look at pattern recognition. When I was a somewhat new nurse, I was taught this, but the turn signal method. So with your left hand or your left arm, if that first inflection is going up, then you're turning to the right, that's a right bundle branch block. And if that first deflection is going down, then it's a left, you're turning left. It's a left bundle branch block. For left bundle branch block in V1, it looks like a W. For a right bundle branch block, it looks like an M. And then the opposite for lead 6. That looks like an M if it's a left bundle branch block and a W if it's a right. So again, just more methods for pattern recognition. All right, quick case study. 80-year-old man with a history of AFib, coronary disease, and an NSTEMI in November 2017. His EF is normal. He did end up with a stent in the mid RCA in 2017. And he has a longstanding right bundle branch block. That was first noted in 2014, so it predates the coronary disease. But he came in with syncope versus a seizure. found slumped in his chair. Neuroconsult was negative. So one of the things that we think about is conduction disease because of that right bundle branch block. This is what it looked like in 2023. And then in 2024, the bundle branch got a little wider. We also had a concern that there's a mild first degree AV block representing conduction disease, and so this patient was recommended to have a pacemaker. In terms of underlying pathology for right bundle branch block, we think about things that are going to strain the right heart. So patients with pulmonary hypertension who have right heart strain could have a right bundle branch block. Patients with congenital heart disease, again, sometimes there isn't any pathology associated with it. It just represents primary conduction disease. Left bundle branch block case study, 79-year-old patient with non-obstructive coronary artery disease. He has vascular disease elsewhere and quite a wide QRS duration, 170 milliseconds, normals under 120. Non-ischemic cardiomyopathy with a low EF. And that left bundle branch block dates back to at least September 2019. And here's his EKG. Again, using the turn signal method in V1. The first deflection is down, so we're turning left. That's a left bundle branch block. His heart failure was treated with guideline-directed medical therapy. Because he had a very wide QRS, he ended up receiving a biventricular pacemaker or cardiac resynchronization therapy with leads both on the right and the left side of the ventricles to help the lower chambers resynchronize and squeeze more effectively. And this helped to improve his ejection fraction. Left bundle branch blocks can contribute to a cardiomyopathy because the left bundles are not conducting the normal electrical signal. It goes down the right lower chamber and then it has to beat cell to cell. So the right side beats first, and then there's a delay with that signal getting over to the left. And that can create some dyssynchrony in the pump. And that's what the biventricular pacemaker or resynchronization therapy is for. So left bundle branch blocks can cause cardiomyopathies. They can also be a manifestation of cardiomyopathies, especially people with coronary artery disease who have infarcted, as well as patients who have non-ischemic cardiomyopathies, so weakened heart pumping function for reasons other than a heart attack. And when that left ventricle dilates, it can create the left bundle branch block. Moving on to the QT interval. The QT interval that measurement is a biomarker for the risk of torsades, a very particular type of ventricular fibrillation. QT is relative to the heart rate. So we would expect the QT interval to become shorter when patients have higher heart rates, and that QT interval can lengthen when patients have slower heart rates. We measure QT and then correct it for heart rate. I use the MD calc, and the definition of QT, corrected QT prolongation is greater than 500 milliseconds. So the QT interval represents the ventricles depolarizing, so the electrical signal moving down the lower chambers, and then that T wave represents the heart resetting electrically. Again, it changes with heart rates. We would consider a QTC like up to 480 normal. A prolonged QT, again, puts someone at high risk for ventricular arrhythmias. A QT can be prolonged because someone may have a genetic or an inherited long QT syndrome. It could be drug-induced, so QT prolonging agents, many antiarrhythmics, particularly dofetilide or Ticasin, and sotalol. Those are in the same class. Those are class 3 antiarrhythmics, and they can potentially prolong the QT. Again, bradycardia can prolong the QT. Electrolyte derangements can prolong it. Other medications, common medications, certain antibiotics such as Zithromax or azithromycin, the ciprofloxacin, levofloxacin, those are big QT prolonging agents. Bactrim is also a big QT prolonging agent as well. This is a patient I saw recently, 74-year-old man. He had mitral valve prolapse with severe regurgitation and was also found to have a left atrial mass. He had a surgery that was scheduled, but prior to that scheduled date, he presented to an outside hospital with acute dyspnea, acute heart failure, pulmonary edema, possible superimposed pneumonia, and he was in new AFib with rapid rates. He did spontaneously convert. They did give him metoprolol and other rate-slowing agents, and then he was started on amiodarone, and he was transferred to our facility a few days later to be optimized for surgery, and then he underwent his mitral valve repair. They removed that left atrial mass. I think it was a myxoma. But he became quite bradycardic, and the QT interval became prolonged. This is almost 600 milliseconds. So the amiodarone that they were using to treat the AFib was discontinued. A quick word about amiodarone: while it can cause QT prolongation, it is pretty rare that that leads to torsades, but it's still something that we don't want to take a chance on. Once the amiodarone was discontinued, his heart rate picked up, and the QT interval improved. He has had recurrent AFib, and we're working on managing that. Um, I think some of my slides maybe got out of order. I'm going to skip premature atrial contractions. I don't think that's necessarily something that you would see under urgent or emergent circumstances. But the one thing that I do want to mention is that patients who have frequent premature atrial contractions is that can be kind of a mimicker of atrial fibrillation because it creates that irregular rhythm. And some patients can be symptomatic with a lot of frequent ectopy. PVCs, premature ventricular contractions. Um, you can see how the QRS is distorted. Uh, again, PVCs aren't necessarily something that's going to create a patient necessarily to decompensate. But the one thing that I will say is that patients who have frequent PVCs, these beats do not perfuse like a normal heartbeat. And so oftentimes patients can be found to have what we consider to be false bradycardia. So someone might have PVCs every other beat. Their heart rate is normally 70 beats a minute, but because the PVCs aren't perfusing, it's being registered as 35 beats a minute. Again, if patients are asymptomatic, that's not a big deal. That's something that can be treated in the outpatient setting. Um, PVCs can occur every other beat bigeminal. Um, 3 beats in a row, it would be considered a triplet. Once there's 4 PVCs in a row, we would consider that to be non-sustained ventricular tachycardia. Okay. Moving on to some common atrial arrhythmias. Typical flutter is something that you may see. It's a rapid circuit in the right atrium. It generally beats in the atrium at 300 beats a minute with a 2-to-1 block. And there is a very distinct pattern to typical atrial flutter. And I'll show you an ECG, but in leads 2, 3, and AVF, those flutter waves are inverted and they're positive in V1. This is just a representation of normal anatomy, normal conduction. But what happens in flutter is in the right atrium, it's usually can be triggered by a premature atrial contraction. But what happens is it goes to the AV node and back down and keeps spinning around. And here is classic typical atrial flutter. These are the flutter waves. They're inverted 2, 3 AVF. They're positive in V1, usually positive in V2, but around V3, V4 is when they start to invert. This is a 12-lead rhythm strip, again, just showing that classic pattern. Atrial flutter is very responsive to heart rate, AV nodal blockers, heart rate slowing agents, metoprolol. It could potentially convert with adenosine, but that's not something we would use commonly for typical flutter. These rhythms can be persistent, they can be paroxysmal. Sometimes patients terminate on their own. Um, One of our biggest concerns with um, atrial flutter, atrial arrhythmias is the risk of thrombus. But because atrial flutter occurs in the right atrium and it's a much more organized rhythm compared to atrial fibrillation, is the risk of thrombus formation is far less than what it is in AFib, but you would still want to anticoagulate these patients. Um, for patients in rapid flutter who are unstable and or the rate is difficult to control, this could be cardioverted with a synchronized shock. Um, Again, the risk is that if someone has been in this longer than 24 hours, there is potential for clot formation. So the safest way to do this is to um, image the heart to make sure there's no thrombus before cardioverting. Obviously, something that's not possible in your line of work, but something we would do in the hospital just to mitigate a patient's risk for stroke. This patient was started on anticoagulation and then underwent an ablation for the cavo-isthmus tricuspid line. Cavo-tricuspid isthmus. Atrial fibrillation is a cousin to atrial flutter. If patients have typical flutter, they are prone to develop atrial fibrillation in the future. That timeline is unpredictable. We have a bigger concern with AFib as it can be a risk factor for stroke. And again, it's very common. AFib is a very rapid, irregular, chaotic arrhythmia that originates in the left atrium, and it causes the atrium to fibrillate or quiver. The left atrium has a vestibule, an appendage off of it that doesn't really have any contractility to it. And that's where 90% of the clot due to AFib is likely to form. So for patients in AFib, one of the first lines of treatment is anticoagulation. We do not know why people get AFib, and we do not have an absolute cure for AFib. But the three biggest contributors to atrial fibrillation are uncontrolled hypertension, untreated sleep apnea, and alcohol. Usually, AFib related to alcohol has more to do with something called holiday heart, where people go to a special celebration or a holiday party, they overindulge, and they can develop atrial fibrillation later that night or the next morning. Respiratory illnesses can be a trigger. Being in heart failure can be a trigger. Heart failure can also trigger AFib. So if someone has both, it can often be a chicken or an egg issue, like what came first. So again, just AFib originates in the left atrium. It primarily originates around the four pulmonary veins that those are the veins that bring the oxygen-rich blood from the lungs into the left atrium. We do not know why the AFib signals originate there. There's actually a French electrophysiologist who's in the Bordeaux region who initially described this and then developed ablation techniques. But That rhythm goes on to affect both atrium in that they quiver and they beat quite rapidly. You don't see any P waves, and there's a very irregular R to R interval. So the hallmark is an irregular tachycardic rhythm. This is a patient I follow in clinic. He was diagnosed with bladder cancer and actually came in for a surgical procedure to treat that. He was found to be in AFib with RVR. The biggest concern with AFib, in addition to the risk of stroke, is that when someone is in AFib and it is persistent over weeks to months, and it's either untreated or unrecognized, because sometimes even with these very fast heart rates, patients can be asymptomatic. Patients can go on to develop a cardiomyopathy related to those rapid rates. And that's what happened to this younger gentleman. His ejection fraction dropped to 15 to 20%. It was challenging because we needed to treat the AFib, treat his heart failure, and get him healthy enough to get him back on track for his cancer treatment. We initially rhythm controlled him with amiodarone. He was anticoagulated with Xarelto. He got through his surgical procedure, and he ended up having an ablation for AFib. Again, ablation is not an absolute cure, but it's the best way we have to suppress AFib, even better than antiarrhythmics. And here's his 12-lead EKG. Rates are about 150, and there's an irregular R to R with no clear P waves. And so he is now doing well post-ablation, and with rhythm control, his ejection fraction normalized. Treatment for atrial fibrillation, anticoagulation with warfarin, or an oral, a novel oral anticoagulant such as Eliquis or Xarelto. We're using those more and more. We don't see a lot of warfarin anymore. The advantage to apixaban and Xarelto, or Eliquis and Xarelto, is that there is a rapid onset, versus with warfarin, when that is first started, it can take 3 to 5 days to reach a therapeutic level. With the novel anticoagulants, once those anticoagulants are discontinued, 75% of the drug is metabolized out of the system within a 24-hour period, versus warfarin, once that's discontinued, that can take 5 to 7 days for it to metabolize out of the system. The advantage to being on warfarin is we do have vitamin K, which can reverse the effects, but vitamin K also has a short half-life. If someone has a super therapeutic INR, let's say, 6.5, and it needs to be reversed, vitamin K is given, the INR will drop, but then the vitamin K will wear off, and then the INR will sort of trend up again. It's not a long-lasting reversal agent. With the novel anticoagulants, there are reversal agents. They are quite expensive. Many hospitals don't stock them. And the biggest concern with that is giving those agents can sometimes be prothrombotic, and then we end up with other problems. So patients with AFib require anticoagulation to reduce their risk of stroke. We always want to work on controlling the heart rate, generally with a beta blocker, sometimes calcium channel blockers, and sometimes digoxin. And then rhythm control that can be achieved either with cardioversion, antiarrhythmic medication, amiodarone, very common. I'm sure that's something that you're exposed to quite a bit. Amiodarone also has some beta blocker properties and can sometimes assist with heart rate control. Some antiarrhythmics have the risk of chemically converting patients back into a normal rhythm. And so we have to be very cautious with that, especially if patients are not anticoagulated and if the AFib has persisted for an uncertain period of time. Ablation, catheter ablation, very effective to suppress AFib longer term. And then oftentimes we're using a combination of all three of these strategies. Any questions about AFib? Okay, I'm gonna move on to other atrial arrhythmias. Very commonly, SVT, one of the most common forms is an AV nodal reentrant tachycardia. It tends to affect women more than men. Patients often describe this as a sudden onset, like they're out in the world minding their own business, and it's like a light switch just came on and their heart is off to the races. The rates can be very rapid, sometimes greater than 200 beats a minute. Even despite those rapid rates, these patients tend to tolerate SVT. They might feel pre-syncopal, but it's very rare that they pass out from SVT. They usually just feel the very rapid heart racing. The biggest concern is for those patients with underlying heart disease, especially coronary disease, because this tachycardia could create like a demand ischemia. Patients who have cardiomyopathies or heart failure might not tolerate the tachycardia. This could lead to shortness of breath, fluid retention, that kind of thing. Sometimes these rhythms are responsive to Valsalva maneuvers. So having patients take a big deep breath and bear down, sometimes drinking something really cold. In my experience, I feel like the Valsalva maneuvers work. They don't work more often than they actually do work, but it's certainly worth a try because it's something that's just very accessible and easy for the patient to do. SVTs are responsive to adenosine. So adenosine, 6 or 12 milligrams given rapid IV push, it transiently blocks the AV node and allows the sinus node to kick back in. As you probably know, some patients tolerate adenosine just fine. Other patients can feel like there's impending doom because it does it slams on the brakes, and there can be a significant pause when the SVT is converting back to sinus rhythm. SVTs generally do not respond at all to AV nodal agents like metoprolol. It's kind of one of my pet peeves when I see patients in clinic and they've been put on metoprolol to quote, prevent SVT. In my experience, SVT has a mind of its own. It is generally not triggered by anything, exertion, stress, whatever. It's usually patients are, like I said, just going about their day-to-day life, and it's like a light switch goes off. The hallmark for common AV node reentrant tachycardia, it's generally a narrow complex, but it's what we call a short RP. So there is a retrograde P wave, and you see it immediately after that QRS complex. And that is pretty much a hallmark sign for AVNRT. Um, I don't know how much WPW you might see out in the field, but I did want to give it a mention. Patients that have WPW are born with some sort of accessory pathway, which can be right or left sided. Um, and there are there's subtle yet distinct EKG features um, that are indicative of Wolff Parkinson White. Patients who are asymptomatic, we generally do not worry about WPW, but one of the biggest, although somewhat rare concern is that patients can die suddenly. And that is usually when they're in some type of atrial arrhythmia, either typical flutter or atrial fibrillation, where those very rapid chaotic beats from the atrium are conducting down both the AV node and the accessory pathway. And that was the EKG that I wanted to show you today. So this is just a very crude illustration of sinus node going down the AV node and then going down the conduction system in the ventricles. So you see the P wave, the PR interval, the sharp J point, oops, and then the T wave. With Wolff Parkinson White, like I said, there can be an accessory pathway, either left or right sided. This is depicting a left sided pathway, and what happens is the beat from the sinus node goes down both the AV node and the accessory pathway, but the accessory pathway conducts it much more quickly than the AV node can. And so what you get is this delta wave, kind of this upslope, this ski slope, this slurring of that J point. And that's evidence of this accessory pathway conducting that sinus beat rapidly down the lower chambers. And again, it is very subtle. Sometimes you don't see it in all the leads, but here you can see it in V3. I actually had to look at this EKG a couple of times because I'm like, is that my WPW EKG? And when someone has an accessory pathway and atrial fibrillation, that can set them up for all kinds of badness. But on first glance, this looks like it could be VT or VF because it's conducted very rapidly. Um, but in V2 and V3, you do see, even in V1, you do see the delta wave. So this ECG represents AFib that is occurring in a pre-excited heart. Special considerations for atrial arrhythmias for those patients who have WPW is it's important to avoid adenosine and avoid any AV nodal agents. Oh, one thing I wanted to discuss real quick. The biggest concern is that while this is AFib, being conducted down both the AV node and that accessory pathway is that having that accessory pathway, you can get almost one-to-one conduction, which is going to be very fast. And this is something that can degenerate into VF. And so for any patient who has WPW and atrial arrhythmias, the best course of treatment long-term would be an ablation. However, if patients aren't aware that they have AFib or they're having the first event and they're pre-excited and going very fast, we want to avoid anything that blocks the AV node, because what happens then is everything will get conducted down the accessory pathway, and that's when we get degeneration into VF. Procainamide is okay because it doesn't have any AV nodal blocking effect, and it can slow as well as convert patients out of this rhythm. That's something that might be more challenging in your line of work, in that if you are unable to see the delta wave on the EKG, or have concerns, what you're seeing is more of a wide complex tachycardia concerning for VT or VF. If the patient is unstable, I would imagine then that you would follow ACLS protocol and perhaps cardiovert them out of it. But it may not always be possible for you to know that a patient has an accessory pathway. If it's known to the patient, obviously that's helpful information that, hopefully that they would be able to give you. I just have a few more slides. I know it's a little past 7, and I also wanted to leave time for any questions. But I wanted to talk about patients in VTVF, and in particular, this one patient of mine who had an ICD. So this is one of my favorite patients, 75-year-old guy. He has known hypertrophic cardiomyopathy. And that was initially diagnosed in 2020 when he was at work and had a cardiac arrest, had no known heart problems prior. He was successfully resuscitated, brought into Anschutz. That's when he was diagnosed with HCM. He received a dual chamber defibrillator for secondary prevention, and did really well for 4 or 5 years. And I had just seen him in clinic. We did a device check. We had a really nice visit, and everything looked great. He had not had any further arrhythmias. And the next day, literally the next day, he goes golfing and collapses in front of his buddies. This is the tracing, the EGM tracing from his defibrillator, which looks similar to a telemetry strip, but it's different. I don't imagine or expect that this is something that you would see and or read very often, but I can tell you that this is a normal beat here. So backing up, this is the atrial channel. So we see the atrial activity up here. This is the ventricular channel down here. This down here is a shock lead, or something that's a discriminator that basically helps the device to differentiate between atrial and ventricular arrhythmias. But he's in a normal rhythm. He's asensed, V-sensed, one-to-one conduction, sinus rhythm, asense, V-sense, and then asensed here, he has a PVC come in, and it's just like off to the races. This is well over 200 beats a minute. The same rules apply for heart rate calculation in looking at these EGMs, just like we're looking at telemetry or an ECG. But if an R to R interval with one box between it is 300 beats a minute, this is just shy of that. And so he goes into VF. The device is trying to overdrive pace him out of it. That's what we see here. The ATP or the overdrive pacing ends here. And as you can see, he remains in VF. The device is charging. A shock is delivered. And unfortunately, it is not successful. He remains in VF. So he remains in VF. There's some time it takes for the device to redetect. It charges again. And then here he does end up breaking. So VSENS, PVC. But anyway, he is mostly back. He is having some PVCs, but he's back in a normal rhythm. So for patients that you see who have defibrillators and it's obviously not converting them out of it. There is no harm in externally defibrillating these patients. It's probably the best thing to do rather than waiting for the ICD to redetect the arrhythmia and charge. It also will not hurt the defibrillator. If the defibrillator patches are placed near or over the ICD site, you're not going to harm the ICD that way. And every now and again, I think the myth is largely dispelled, but every now and again, we get patients who their family members are afraid to go near them if they know they're getting shocked from their device because they're afraid they're going to get shocked. Obviously, that is not going to happen. You can touch the patient without anything happening to you. Same thing with pacemakers. If you have a patient with a pacemaker or other implanted cardiac device and they're, say, in unstable atrial fibrillation or unstable narrow complex tachycardia and require cardioversion per ACLS protocol, again, those defibrillator patches are not going to hurt the implanted cardiac device. I will wrap things up here and am happy to take any questions. The one thing that I do want to leave you with is that in the field, if you are caring for a patient, resuscitating a patient in a cardiac arrest, if there is any way to save the rhythm strips from the defibrillator, that's really helpful for cardiology and especially electrophysiology when we're trying to figure out what rhythm were they in and, do they potentially need an ICD or not. So if there's any way those rhythm strips can be saved and passed on to the treating hospital and or given to the family members. I've had that happen before where they've hung on to it and then they bring it and show us. Lastly, I took this picture when I was in Chicago, October 2022, so just a couple years after the pandemic. Thank you for the work that you do and the care that you provide to the people in your community.
Thank you so much. I put the CE link in the chat, so make sure you get your CEs, and this is your chance to ask any questions.
And also, Andra, if this is a reoccurring segment, like it would just be really helpful to know for any future presentations to have some feedback on what's helpful information, what isn't, what you would like to hear more or less of, just to be able to tailor the presentation.
Absolutely, will do. Thank you. And
Okay,
we actually get feedback for when they fill out their CE form as well. So if you guys
okay,
have any
great.
constructive stuff, put it in there.
The hard part for me is should have said this in the beginning. Like I said, I'm primarily clinic based. I do a little bit of hospital. I've never done any emergency medicine. Obviously, I've been involved in codes and ACLS, but far different than the work that you do in the field.
Alrighty. Well, thank you again for spending your evening with us. And if you guys got your CEs, you're all set to go.
Okay, thanks for your patience and your attention today.
Thank you.